Hi, this is Dr. Alice Lee. Welcome to iCubed. This is EMN's newest blog, and I'm so happy that you've joined us. I have been in clinical practice for more than 20 years here in Arizona. After doing my residency at Maricopa Medical Center in Phoenix, I'm really excited about this endeavor, and thanks for joining me. This blog is intended for you and I, the clinician. Just imagine you are chatting with your colleague over a coffee, or maybe you're having a bite of pizza, and you are picking each other's brains and sort of curbside consulting your colleague. My guests will have no prior knowledge of the case, and hopefully we'll all learn something practical or useful as we go through the case. So here we go. So Marc, why don't you introduce yourself?
My name is Marc Zosky. I'm a recent addition here at Banner Bay Wood. Graduated from LSU Baton Rouge about 6 months ago, and I've been living it up in the desert since. So happy to be here. Alice Lee is wonderful.
So we're just going to dive on into this case that I saw roughly 18 months ago. I didn't know the actual diagnosis until after the whole case was done. I thought that this is a very, very good case to just go through and share with my colleagues. So here we go. This is a 76-year-old female who presented with diffuse abdominal pain. It apparently radiated to the chest and to the back. It started about 6 hours prior to coming to the hospital by ambulance. Apparently it was really mild at first, but very quickly it worsened to a point where she was actually vomiting. There was no diarrhea, and she didn't have any fever. The paramedics gave her nitroglycerin and aspirin by protocol, obviously, but it didn't really help her at all.
So right off the bat, this is a very typical patient we see here at Banner Bay Wood, elderly female with abdominal pain. Mm-hmm. And just our population, it's very rare we ever see anyone, too, that has no medical problems or no medicines. That they usually have CHF, hypertension, breathing disorders, and have a laundry list of problems, and they're very complicated. So just the history that concerns me the most is that the pain is pretty quick onset, it's worsening, and it radiates to the back. And as ER doctors, we're trained to think of the worst. So this patient could have a AAA, she could have a perf viscus, she could have a dissection, this could be maybe an anginal equivalent. She could have gut ischemia, mesenteric ischemia. So this patient is going to get very close attention, needs a very focused exam, and we'll see what the story unfolds.
Right. So we get a little bit more history from her in her chart. She has a history of hypertension. She's had a cholecystectomy, hysterectomy. She's never smoked and doesn't drink any alcohol. Her meds are actually very commonly seen in the elderly around here: amitriptyline, atenolol, hydrochlorothiazide, lisinopril, and zolpidem. So going to the physical exam, this is a lady who looks sick. She was grimacing, elderly, thin lady. She was holding her belly. You know that she's in pain. She's quite uncomfortable. Her vital signs are as you see, with blood pressure slightly elevated, 154/71. Her pulse is only 59. Respirations are 18, not your requisite 20. I think somebody actually counted her respirations this time.
Oh, so it's a real respirations of 18, not that everyone in the department is 16 to 20. Did this patient have a fever, Alice?
She did not have a fever.
Or maybe we don't know yet, because that's sometimes the last vital sign we get.
Yes, I don't know if that's true for the rest of you in the world, but it's certainly true for us. On the exam, we do a focus exam, we meaning the emergency physicians, especially on someone who's coming in such distress with abdominal pain. So on my exam, she had a very soft belly, actually. She had normal sounding bowel sounds. She had a little bit of rebound, maybe, and a little bit of guarding, but really soft otherwise, quite distended. But she was rather tender in the lower abdomen. So kind of unimpressed by the exam, given how much pain she appeared to be in. So what do you think, Marc, at this point?
Well, with her being that distended, and in that much pain and guarding, the concern for a surgical abdomen is there. Did she perforate her viscus? Does she have, what's very common in the elderly, or more, I should say more common in the elderly, is that she have like a sigmoid volvulus. That's why she's that distended.
Right.
Is there fluid in her belly? Is there blood in her belly? The reassuring thing is that her vitals seem okay for now. She's not horribly tachycardic. She's not hypotensive. Her respirations are okay. She's satting well. So she's going to get a very large workup, a full panel of labs. She has a very broad differential, and many things on the differential are quite serious.
Right. So one small point, let me just insert here. The lack of tachycardia can be a little deceptive on the elderly because they're oftentimes on the beta blocker. So you have to be very mindful on the elderly who are oftentimes put on beta blocker due to hypertension or atrial fib or just coronary artery disease. So this lady having the lack of tachycardia isn't actually reassuring and may be actually somewhat deceptive. So for me, obviously, one of the first things to think about with her would be a AAA. Here at Banner Baywood, and then probably in any retirement community, aortic disease is very, very common. With the perforated viscous, I was not really thinking that just because she did not have a rigid abdomen. Ischemic bowel, top of my list, renal colic, perf api, pancreatitis, cholecystitis, and gynecologic disasters were all in my differential for her. So how do we get through these differentials? How do we dissect them or parse them out?
So we kind of discussed earlier, she's going to get a big workup.
Yep.
We have the ability to do point-of-care lactic acids here. We can get them usually at the bedside in a couple minutes. So that would be my first test. And if she's really high, that'd be really concerning for mesenteric ischemia or, just hypoperfusion in general.
Right.
Also, she's going to get imaging, and then you can kind of think about the utility of point-of-care ultrasound. I didn't even think about this earlier, but Alice busted it out with her skills. That's absolutely appropriate, especially for AAAs. Having been recently trained, I'm at least I could say competent. I'm not an amazing ultrasonographer, but I'm competent. And the good thing is if you're doing an ultrasound of the AAA or of the mid-abdomen to look for a AAA, if it is a large, surgically relevant AAA, I almost say a medical student could find it because it will be massive. And if you're having to hunt for it for 20 minutes there, it's probably not there.
Exactly.
And in addition, you can do almost like your regular FAST exam, look at the right upper quadrant, the left upper quadrant, the pelvis, and see if there's just fluid in the belly. Right.
Excellent thoughts. So in this case, I did the usual metabolic workup, chest film, EKG, CT. It was certainly on my mind with her. Ultrasound at the department, ultrasound department was certainly on my mind. But you know what? Having become a recent ultrasound evangelist about 4 years ago, thanks to Dr. Teresa Wu at Banner University Medical Center, we as a group went to a introductory course down at Banner University Medical Center, and ever since then I've been just really enthusiastic about using bedside ultrasound. So what do you think I did on this patient?
I'm guessing you did a bedside ultrasound. And I was looking at you go, and I am thoroughly impressed. And I really am. I'm not just saying that. And the reason is when you do a right upper quadrant ultrasound, you can get the diaphragm view, you can see the liver, you can see a bit of Morrison's pouch in the kidney, but if you don't move that probe inferiorly and get a complete view, you would have missed that very significant finding that you got there, Alice. You have the caudal tip of the liver has what looks like a significant amount of black anechoic, you presume it's fluid. So that's important. Yep. So props to the ultrasound skills, Alice Lee.
So in the meantime, the labs come back, and as you see, the white count is quite high. Now, props to Dr. Amal Matu, who thinks that white count is the last bastion of the intellectually destitute, I believe.
Mm-hmm. I still look at it.
Well, in this case, it seems to kind of confirm our clinical suspicion that this lady is really sick with something pretty bad. And so we look at the remainder of the studies. We did the diagnostic radiology. The X-ray looks pretty unremarkable. You're looking for, let's see, free air. That's an old way of looking for free air. since I was trained.
Quick and dirty. Just look under the diaphragm for black streaks.
Exactly. So then we get a CT, regardless, even after the bedside ultrasound, and this is what we find on CT scan. What do you see, Mark?
I'm looking for the positive arrow sign from the radiologist who points me to where I'm supposed to be looking.
Nope. Here's another view of it. I'm going to help you all out by pausing it. So right here,
looks distended.
Yeah. So right
Very
here,
distended.
On my cursory look at the CT scan, I can see multiple things that are wrong. Obviously, you see the colon that is distended down in the right lower quadrant. I don't know what that is exactly, but obviously it is abnormal. And then I notice this shadow on the liver, and I think that's fluid. Here's another view. I don't know about you, but I like looking at the CT scans of my patients, and I like to review them, and I like to correlate them with my clinical exam and my clinical suspicion. At this point, I don't exactly know what's wrong with her yet. I know she's sick. I know she's got free fluid. I know she's got an abnormal intestine on the CT scan. And radiologist reading is mechanical small bowel obstruction in the distal ileum. It is difficult to determine whether this is due to a transition of the bowel or possible torsion. There's also a small hiatal hernia. What do you think, Mark?
So, at this point, at least to help her, I think she would get an NG. Surgery would be consulted. I believe her past surgical history was cholecystectomy and hysterectomy.
Correct, yep.
So she's at risk for small bowel obstruction. She's likely got some adhesions. That is the number one cause.
Yep.
So she's with I don't like auto putting NG tubes in, even though that's the general practice. But this patient I would, especially because her abdomen was distended and she's in as much pain. So I would put an NG tube in, bless her heart, they hurt like heck.
Yep.
Try to decompress that, see if she needs another dose of pain meds. She already got fluids, and then get the surgical services recommendations.
Right. So I did actually talk to surgery early on after my bedside ultrasound, and the surgeon wanted us to proceed with the CT scan. In my mind, this is my generation of ER doc training, I guess, which is that if you find free fluid, you should just go to the OR. You make an assumption of a perforated viscous of some sort. However, in this particular case, our surgeon wanted us to proceed with the CT, and we did. Once the CT came back, I talked to the surgeon, and she took the patient to the OR. Now, it was after this shift that I went to follow up on what happened with this patient.
So I'm going to stop you right there, too. So busy ER, elderly patient with abdominal pain, gets a full workup, close attention. She gets a CAT scan, small bowel obstruction, talk to surgery, boom, you're done. Your disposition is made.
Yep.
Off to see the next patient.
Correct.
So I'm guessing, though, with more slides, something happened or
Yes.
something interesting happened. But that's where my thought is, at least as a busy, community doc, is we've made a diagnosis, we provided a therapy, we've got the disposition, the consultants on board. High fives, next patient, done.
Close this chart.
Sign the chart, move on.
Move on. Yep.
So I'm interested to see what happened, or hopefully what I missed or did not miss.
Well, we'll all see. And we'll learn from this. Because I was concerned about her. I didn't know the diagnosis, and naturally I went ahead and followed up on her. The surgeon's findings were that there was an internal hernia with a small bowel in the pelvis that was caused by an adhesive band. So these are the intra-op findings of the surgeon that I found in the chart later on.
42 centimeters of ischemic bowel.
That's
That
right.
is a big deal.
Right.
Wow.
Exactly. It was a remarkable case. So there was basically an internal hernia with a small bowel herniating through adhesive bands.
Wow.
So fortunately, the surgeon took laparoscopic pictures first.
So, not a surgeon, but guessing the dark color is not good? Is that what that is?
So, you'll see on the left upper corner there, where the arrow is, this is just a distended small intestine that is ischemic in purple. here's another view of another portion of the distended intestine. That's probably part of the ileum that was resected. So the surgeon, here's another view. So the surgeon went in and did the laparoscopic peek first, and then opened her up to finish the ileal resection. And here's another view of the ischemic bowel.
I forget, Alice, did the initial CAT scan not comment on infarcted bowel?
Correct.
Ooh. I wonder if that's a limitation that we didn't have contrast to do it, or if it was just, I'm not an expert at reading these films, so I've ordered plenty of non-contrast abdomen pelvises. I've been in this situation. I'm wondering if I'm missing infarcted bowel.
Right. So I think this is worth discussing, meaning do we order CAT scans with contrast or without? And I think that's a difficult decision to make, or at least it's very difficult to make a rule, because it depends on the individual patient, the body habitus of the patient, and how urgent it is to make a diagnosis. In this lady who was really quite ill, who in my mind actually needed to go to the OR, but working collaboratively with our general surgeons and our staff, I went ahead and ordered a CAT scan, but I wanted to get it done really pretty quickly. So I didn't want the hour delay that would be required for oral contrast. And she was also vomiting earlier, so I didn't order any oral contrast. So this is the image that correlates with that ischemic bowel that you're seeing.
Mm-hmm.
Where the yellow arrow is. So that is exactly where the surgeon, took out the ileum. It was all infarcted because it had been choked off in the hernia. Yep. I'm planning on having a couple of learning focuses for each of my screencasts.
Does that mean that after this I only have to remember 2 things from my small brain?
Yes.
2 things.
Yes.
I think I can handle 2.
Yes, I think even you, Marc
Even I can
Zosky,
handle 2.
Dr. Zosky can handle 2. So what is our learning focus number 1? Well, pain out of proportion to exam equals ischemic pain. Pain out of proportion to exam equals ischemic pain. This is a lesson, an idiom, a mantra I've learned from eons ago when I was a baby ER doctor. And this particular case really, really illustrates it. This lady, you knew she was sick, but her belly was really unimpressive. It was soft, it was distended, but soft. It's not a rigid belly. So in someone that you're not suspecting is a drug seeker, you really have to think about some kind of ischemic event going on in her gut that's causing this distress. Now, even those, and I guess this is an aside, even the drug seekers can have ischemic pain. What kind of clinical entities can you think of other than ischemic bowel that would fall under this?
Oh, pain out of proportion to exam, you're talking about?
Mm-hmm.
Oh, other than this belly, neck fash.
Right.
Neck fash, absolutely. So skin and soft tissue infections that don't look that remarkable, but the patient is way more uncomfortable than they should be. Mm-hmm. And then if you start redosing narcotics over and over, and then you kind of have to scratch your head and go, what's going on here? What am I missing? Maybe go check the compartments again, range of motion them. Do they warrant further imaging with a CT, or just call a surgeon right away and get them on board faster?
Right. That's an excellent one. So I went through, in my mind, in my clinical experience, what other clinical entities would fall under this dictum. So in this lady's case, obviously it was an ischemic bowel, but your STEMIs is ischemic pain, right? Your exam sometimes really doesn't match how much pain the patient is in. Any of the torsions, ovarian torsion is a little bit harder even than the testicular torsion because it's an internal organ. That's an ischemic pain. Compartment syndrome, Dr. Zosky mentioned. PAD claudication. I mean, this is a fairly okay looking leg, but he or she, the patient, is in a tremendous amount of pain. Acute ischemic limb, like an embolic leg. fall under this dictum. And then Raynaud's is a similar thing, which is ischemic pain. So these were all clinical entities I thought of when I was thinking about this pain out of proportion to the physical exam. The second learning focus on this screencast is, of course, point of care ultrasound. Since I'm an ultrasound evangelist now, let's talk a little bit, very briefly, about the advantages or the reasons to use a bedside ultrasound. I mean, I think this is a tremendous advancement for emergency medicine practitioners, those who really use it. The bedside ultrasound gives you rapid yes or no questions. Is it a AAA? Is there a AAA or not? It's very simple, I think. Is it free fluid or not? Yes or no. It may not tell you exactly details of those questions, but it gives you a quick yes and no.
Absolutely. So I love ultrasound for the purpose of exactly what Alice is saying. It creates a branch point. Mm-hmm. Do I call a surgeon now, or can I wait for a full workup, or rule out a diagnosis, or bide some time? Because if we saw that AAA in a lady that had a distended belly and had pain, the first thing we do is call vascular surgery. Now, even if vascular surgery wanted imaging, not everyone's surgeons are in-house. So at least he knows now, I have someone with a slightly distended belly, but soft, good vitals, that has a large AAA. I know about them. I'm ready for them.
That's right.
I'm ready to come to the hospital, or I'll come in now. Mm-hmm. So these are branch points that dictate what we're going to do in terms of care. So that's why I like. I mean, I'm not going to sit there and measure that, how large the left atrium is and make a really finite exam finding like that, like a cardiologist would read an echo. But at least
so for most clinicians using ultrasound, it's just like Dr. Zosky said, it's a yes or no question. It's to help us anticipate, help us to notify the staff that are going to be involved, especially experienced physicians that are entrenched in your community. The physicians, the surgeons, or the gynaes or whoever that you're going to need down the road. To notify them quickly is important. To go on with this list, it does improve safety of procedures such as central lines, such as identifying a abscess so that you can know how deep to go. Another advantage of using ultrasound is to improve your overall efficiency of running your ER, really.
My favorite ultrasound is, Alice?
What?
Eyeballs.
Excellent.
I love eyeball ultrasounds.
That's
because if you put an ophthalmoscope in my hand, you might as well... I have no idea what I'm doing with that thing,
Right.
So I can detect a retinal detachment pretty easily
there
with that thing. And that's quick.
Yeah,
Boom.
Excellent. So even Dr. Zosky can do an ultrasound of the eye, so any of you guys out there can do it. All right, so... next thing would be that it does improve patient satisfaction. I have many a times actually shown my young, nervous, pregnant women, that their baby's heartbeat is still okay. Using a bedside ultrasound is basically an extension of your bedside physical exam. Now, you young doctors are so used to testing everything, but us old doctors still rely a lot on our physical examination skills, and using an ultrasound, it does extend that ability. It is a non-invasive study, so it's actually a selling point, to use an ultrasound on someone. There's no ionizing radiation, and with all the increased consciousness of the overuse of CT scan, I think ultrasound is a really valid, better option a lot of times. And it's an ultrasound you can, it is a study you can repeat in the ER, or if you have an observation unit, theoretically you can repeat your exams over there as well. And then once you have your investment in your equipment, it is rather cost effective. Now, it is not without downfalls. It is less accurate in certain patient populations, such as the obese, and we've got lots of those in our world, sadly. It is less accurate if you happen to have ileus, because you've got distension, you've got more air and gas in the belly. If you happen to have cutaneous emphysema, such as neck fash, certainly it would be difficult to view very well. The type of fluid you see can't be differentiated, whether it's blood or ascites or hemorrhage. It is operator dependent, so the person that's you performing the ultrasound. If you're not great at it, your images and your diagnosis will be somewhat less secure. And then it is the machine dependent as well. There are more and more advances in the precision and the clarity of ultrasound. So depending on what your machine is, how old it is, your images will vary in its accuracy. So at the end of this case, what happened to her? Well, she had an ileocecectomy. She was discharged home a couple of days later with a wound vac. And at a 1-month clinic checkup, a follow-up, she was well.
Very good.
So this was a very good case. And I wanted to chat a little bit about this clinical entity of ischemic bowel and think broadly about ischemic pain. And to promote bedside ultrasound, because it did really help me anticipate and to get in touch with the surgeon early on so that the surgeon would be prepared that she may have to go to the OR later on. Thank you, Dr. Zosky, for joining me on this maiden screencast, and we will see you all the next time. Bye.
Bye-bye. Hopefully I'm invited back to the next taping.